So, and Mark, Tony, jump in if you need something. So, the overview of today, we're just going to practice the process and let you guys role play the scenario. So we're going to do 2 breakout rooms. We're going to have Northwood in one room and community care in a room. And so we're going to just do like 30 minutes of working on the mock case, and we'll come back together as a large group and kind of do the report out. So the QI process, which I think we've talked about plenty of times now, but the main 4 areas that we want you all to focus on today are identifying the key problem, doing a walkthrough, planning the change, and the nominal group technique. So the mock case is going to be the show rate from scheduling to first appointment is 90%. The show rate from first appointment to second appointment is 70%. And then the show rate at their 4th appointment goes down to 50%. Mark, do you have any comments? Tony, any comments on that you want to?
Yeah, so the way we want you guys to think about this is apply this to your facility, okay? So let's pretend, for example, that this is what's going on in your facility. And the goal then is to apply the process in terms of how would you address this? How would you go about addressing and figuring out what it was that you were going to change to address this problem? Because I'm assuming that you guys think, well, if we go from 90% to 50%, that's not good within 4 appointments, that we want to improve that retention rate. And so the idea is to actually practice the process. We know that you guys can figure out and identify things, but clinically what's going on. But if you don't know how to do the process, you don't get as much out of that. And so this is a chance to work through it with us there helping and guiding you with it so that you can then learn from it and kind of solidify what we've talked about to be in a better place to use it going forward. Does that make sense?
So breakout room instructions, identifying a key problem, doing a nominal group technique with 1 to 2 potential solutions to the problem, plan the change, 1 to 2 data points to collect. You know, I love data. And then do a walkthrough from beginning to end. So we're going to kind of let you guys lead it, but we'll be there to help you and walk through it all. So we'll kind of go out into the breakout sessions and then we'll work on this and then we'll come back and talk amongst all of us to see kind of what we came up with. All right. Well, Mega is going to send us into breakout rooms.
Yep.
Does anyone have any question before we go? No. All right.
there.
Tony, your group, how did your breakout room go?
I think it went great. I mean, I'm biased, but I think that they came with great ideas. It was a really cool nominal group technique. We had to pretend a little bit because they've already done a lot of interventions. And so one of the caveats was you have no budgetary limits and you could have anything in the world. What would your interventions be? So I think they came up with some great ones, and I think that they got the process down.
Great.
Do you want us to do you want them to present or anything, or
Give us a quick synopsis of kind of what you identified and what you came up with, so we can just hear. Doesn't have to be a PowerPoint, just a couple bullets. I would have them present, not you, Tony.
Yeah, I was going to say, Josh, Tina, I don't think he wants to hear from me.
Yeah, so ultimately, we were looking at the rate from Tina. We chose the 90% to the 50%. Is that, I believe?
Yeah.
Yeah.
From the second to the fourth.
The second to the fourth. Okay. So we identified multiple barriers. More than we were able to just pick three. It was kind of difficult to just pick three things we need to focus on. Let's see. So some of the things that we decided upon were reminder cards with our actual extensions on them, with appointment times and what have you, just as reminders to make sure that they have that in their hand and it's something that they can really touch, feel, and bring with them. Another idea we came up with was to, in lieu of suspension after failed random call-ins, we would kind of just monitor their dose or limit their dose and just split their prescription rather than suspending them from the program for 30 days. Then another idea we came up with was just extending the random call-in time from 12 hours to 24 hours, which helps tremendously. Those things have been implemented already. Getting to where we were able to have some flexibility with things that we aren't capable of doing yet, or we don't have the ability to do yet. Transportation. Ideally, we would hire a transportation aid to get people to and from our appointments. That's going to be difficult for a multitude of reasons, and we talked about this with Tony, and the main one being staff retention in that part. So we're getting two parts of the retention that we need to maintain. So that was kind of my thing. There was just hiring a transportation aid, having a van specifically take clients to and from MAT appointments, even individual therapy appointments, because we know the transportation we have up here in rural Appalachia, it's not the most reliable. Tina, you want to take it from here?
One of the things that I think we're seeing is mental health related issues, how mental health symptoms play into our clients falling out of the MAT programs. So making sure that we're getting the links into making sure that their mental health symptoms are being managed, and making that an easy process. If they miss their med appointment, we get them right in to see someone that day. So making sure that we're offering that, and along with that, more of mental health related groups and things like that, not just substance abuse groups. So integrating both of those together, and then looking at some type of contingency management program, to where if they're coming, maybe not to 4, but if we can get them to week 6 appointments, then they would have some type of a gift card or some type of a contingency management. We start talking about that from the beginning and follow through and see if that would increase our percentages. So those are some things we came up with.
To go off that too, hiring of more staff so we can have the availability to do those groups.
Right.
That's a big one. So in those groups would be ideal. I mean, just for comorbidity, dual diagnosis, but to have the staff availability, because between Tina and I and the rest of the people on our team, we have very, very little time to do much of anything outside of our individual sessions or group therapy sessions. So it would be vital to hire more staff to run and facilitate those groups. And I think that could prove very beneficial with regard to retention and QI in general.
So those were all the interventions. There was a couple that they didn't mention. With one of their thoughts on the nominal group technique was doing a Narcan training or overdose, like during group therapy or something, focusing on the significant risk if leaving the program could have upon you, training on Narcan. And then also focusing on why they chose Northwood to begin with versus other programs, kind of to self-focus. And so they did that, they rated them. And Tina, like number one, their own transport staff and van, then mental health, like a dual diagnosis group, mental health focus, and then contingency management were her top three. And then Josh's top three, his first was the transportation information and direct lines on the cards, a split script and not getting suspended if they miss a random UDS. And then transport staff was number three. So obviously their highest score was, because they both ranked, was having their own transport staff. And then do you guys want us to talk about the data that you were going to collect regarding this cycle? Because all those other things that you selected, we're going to put on the parking lot, and the next cycle, PDSA, would be selected from that list likely. But for the transport staff, what data, what's your primary measure? And then what were the secondary measures that you were going to do?
So, of course, primary measure would be how many clients are actually utilizing the transportation and actually coming. How many did we actually do? And then, of course, we have to take our clinician hat off and put on our administrative hat and say, is this actually cost effective? Is it making sense? Are we going to be able to sustain this over a long period of time? So those are our two main measures.
I think they did fab. I mean, I thought that was fantastic. They did great.
Thank you, Tony.
That was awesome. Nice.
Yeah, that was great.
Good job, Tina.
Dr. Jackson, do you want to give a quick rundown of what we talked about?
Absolutely. I also wanted to weigh in a little bit on transportation. That one thing that the kind of employee that we've had luck with in retaining in the transportation role has been a peer support specialist. I don't know if that's something y'all have looked into, but there's great overlap between those two roles. Obviously, that's a hurdle we all face. It's a huge one for us. As far as the problem we identified, it's just high no-show rate at follow-ups. Contingency management was the first thing that I had mentioned as far as a solution. Increasing incentives to follow-ups, whether it be through payment or bus passes or gas cards, or very similar to what Tina had mentioned. The other problem that we have is really administrative hurdles and the times of intake appointments. We do a lot of administrative tasks at the initial intake, and trying to figure out how to streamline that as best as possible is something that I think is included in problems as far as our no-show rates are concerned. Our third problem would be the number of times we contact patients. We have an electronic system, and I think the patients get confused with the amount of contact they receive from us, and it creates confusion. As far as data points, the first point would just be the no-show rates after 4 weeks. The second data point that I'd thought of was the time of the average intake appointment with us and how long that takes. And then the third data point would be the total number of contacts each patient was receiving. And if we could figure out a better way to communicate with them instead of a barrage of text messages or emails or whatever kind of technological. Maybe that's too many contacts is what we're hearing from a lot of patients. Barriers to change. I talked about how I have 3 different case managers and maybe asking each of them to sort of have their own standardized approach to intakes and trying to figure out which approach worked best for, sorry about that, phone was ringing. So I think to try to streamline our intake appointments, having our case managers each have their own technique and trying to figure out which work best to attaining the GIPRA data and the ASAM data and the HO31 data that we need at the intake appointment. The other thing that we talked about was shared appointments. We typically do, the case manager typically goes first during our intake appointments after nursing, and then the medical team or provider gets report from the case manager and goes in and meets with the patient. I think that streamlining our approach during intake to the best of our abilities, given the administrative things that we have to accomplish, is the biggest issue for us moving forward as far as no-show rates are concerned after intake, as far as things that we can do things about.
I thought Dr. Jackson did a really good job with this and kind of focused in, ultimately on the things that he can control and change and have an influence on. He made a comment about what he was told during residency. You want to go ahead and share that comment?
Well, just not to worry about systems issues. It's like part of the training of residency.
Deal with what you can deal with. Kind of sounds like the Serenity Prayer to some degree, doesn't it?
It's no question.
My
mantra through medical school was, or I guess through residency, was fellowship was a lot of fun. I recommend everybody should go to fellowship in addiction medicine. I highly recommend it. But during residency, my mantra was, I'm just glad to be invited. And it worked for me.
Yeah. So really focusing on those things that you can have an impact on and, thinking about those changes that you can control and that you have control of. And there are a number of things that you have control of that you can influence, that you can change how that goes. And so that it's a better experience for the person who's coming in for treatment, so that's more worthwhile for them thinking about coming back rather than, I don't want to ever come back and experience that again. So balancing some of that stuff out. I thought it was nice.
Any final thoughts or comments from anybody? Well, I think it's been a great 6 weeks. And we hope that we can continue to work with Community Care and Northwood on further QI projects, and feel free to reach out to us as you start to work on additional things, and we're here to support you in any way that we can.
Thank you so much for having us.
Yeah, thank you very much, everybody.
It was a pleasure to work with you guys. I really enjoyed it. And good luck, and we'll help you in any way that we can at any time.
Yes, sir. Absolutely.
I'll get my paperwork done.
Megan and I both put
appreciate
the evaluation link in the chat, and I know Jay will send it out with the recap as well. But please reach out, and we would be happy to follow up with anything that you're going to do in the future.
All right.
All right. Thanks, guys.
Thanks, everybody.
So much. Good to see everybody.
Bye.
See ya.
Bye.